Welcome to Pediatric Case Review. Today we will be exploring meningitis in pediatric patients, a potentially life-threatening condition that requires prompt recognition and management. This comprehensive lecture is designed for pediatric residents and physicians to enhance clinical decision-making and patient outcomes. Let's begin with our first case. A 14-day-old neonate presents to the emergency department with poor feeding, irritability, and fever of 38.5 degrees Celsius. What is the most likely causative organism in this case? Is it A. Group B Streptococcus, B. Streptococcus pneumoniae, C. Neisseria meningitidis, or D. Haemophilus influenza? The correct answer is A. Group B Streptococcus. In neonates under 1 month of age, Group B Streptococcus is the predominant pathogen causing bacterial meningitis, followed by Escherichia coli and Listeria monocytogenes. The pathogen distribution shifts with age, with Streptococcus pneumoniae and Neisseria meningitidis becoming more common in older infants and children. Which of the following mechanisms is not typically involved in the pathophysiology of bacterial meningitis? A. Bacterial invasion via bloodstream. B. Direct extension from sinusitis or otitis media. C. Primary demyelination of nerve fibers. Or D. Introduction through trauma or neurosurgical procedures. The correct answer is C. Primary demyelination. While demyelination may occur as a complication, it is not a primary mechanism of bacterial meningitis. Bacteria typically reach the meninges through hematogenous spread, direct extension from infected sinuses or middle ear, or following trauma or neurosurgical procedures. The resulting inflammatory cascade leads to blood-brain barrier disruption, cerebral edema, and increased intracranial pressure. A 2-month-old infant is brought to your clinic with poor feeding for 24 hours and unusual irritability. Which of the following physical findings would be most concerning for meningitis in this infant? A. Mild diaper rash. B. Bulging fontanelle. C. Occasional spit up. Or D. Runny nose. The correct answer is B. Bulging fontanelle. A bulging fontanelle suggests increased intracranial pressure and is a red flag for meningitis in infants. Young infants often lack the classic signs of meningitis seen in older children. Instead, they may present with nonspecific symptoms like irritability, lethargy, poor feeding, temperature instability, and seizures. This makes diagnosis challenging and requires high clinical suspicion in any infant with unexplained irritability or lethargy. A 6-year-old child presents with severe headache, projectile vomiting, and photophobia for 12 hours. Which additional finding would complete the classic triad of meningitis? A. Fever. B. Seizure. C. Neck stiffness. Or D. Petechial rash? The correct answer is C. Neck stiffness. The classic triad of meningitis consists of fever, headache, and neck stiffness or nuchal rigidity. However, it's important to note that only approximately 44% of patients with proven bacterial meningitis present with a complete triad. Other significant manifestations include altered mental status, photophobia, phonophobia, vomiting, seizures, and in meningococcal meningitis, a petechial or purpuric rash may develop. While examining a 4-year-old child with suspected meningitis, which of the following is not considered a classic meningeal sign? A. Koenig's sign. B. Brudzinski's sign. C. Cullen's sign. Or D. Nuchal rigidity? The correct answer is C. Cullen's sign. Cullen's sign is periumbilical bruising seen in hemorrhagic pancreatitis or intra-abdominal bleeding, not a meningeal sign. The true meningeal signs include Koenig's sign, which is resistance to passive knee extension when the hip is flexed at 90 degrees, Brudzinski's sign, which is involuntary hip and knee flexion when the neck is passively flexed, and nuchal rigidity, which is resistance to passive neck flexion due to meningeal inflammation. Which of the following physical findings is least likely to be present in a 3-week-old infant with bacterial meningitis? A. Bulging fontanelle. B. Poor feeding. C. Nuchal rigidity. Or D. Hypothermia? The correct answer is C. Nuchal rigidity. Classic meningeal signs like nuchal rigidity, Koenig's sign, and Brudzinski's sign are often absent in infants younger than 12 to 18 months due to their immature nervous system. Instead, young infants typically present with nonspecific signs such as irritability, poor feeding, lethargy, and bulging fontanelle. Hypothermia, rather than fever, may be present in neonates with meningitis, making early diagnosis particularly challenging in this age group. A 5-year-old presents with fever, severe headache, and vomiting for 6 hours. Neurological examination reveals irritability but no focal deficits. What is the most appropriate next step in management? A. Immediate antibiotics without lumbar puncture. B. CT head followed by lumbar puncture. C. Lumbar puncture without prior imaging, or D. Viral PCR panel only? The correct answer is C. Lumbar puncture without prior imaging. In a patient without signs of increased intracranial pressure, focal neurological deficits, altered level of consciousness, or papilledema, lumbar puncture can be safely performed without prior imaging. CT scanning is indicated before lumbar puncture when there are concerning signs for increased intracranial pressure. Importantly, antibiotics should not be delayed if lumbar puncture will be delayed, as CSF cultures may remain positive for several hours after antibiotic administration. A lumbar puncture is performed on a child with suspected meningitis. CSF analysis shows WBC 950 per microliter with 95% neutrophils, protein 150 mg per deciliter, glucose 25 mg per deciliter with blood glucose 110 mg per deciliter. What is the most likely diagnosis? A. Bacterial meningitis. B. Viral meningitis. C. Fungal meningitis. Or D. Aseptic meningitis? The correct answer is A. Bacterial meningitis. This CSF profile strongly suggests bacterial meningitis with elevated white blood cell count predominated by neutrophils, elevated protein, and significantly decreased glucose level, less than 40% of serum glucose. In contrast, viral meningitis typically shows moderate lymphocyte-predominant pleocytosis with normal to slightly elevated protein and normal glucose. Fungal meningitis usually presents with lymphocytic pleocytosis, markedly elevated protein, and low glucose, but typically with lower cell counts than bacterial cases. A 7-month-old infant presents with fever, irritability, and a bulging fontanelle. You suspect bacterial meningitis. What is the most appropriate empiric antibiotic regimen while awaiting culture results? A. Ampicillin plus gentamicin. B. Vancomycin plus ceftriaxone. C. Acyclovir alone. Or D. Ceftriaxone alone? The correct answer is B. Vancomycin plus ceftriaxone. For infants beyond the neonatal period and children, empiric therapy should include vancomycin plus a third-generation cephalosporin like ceftriaxone or cefotaxime. This combination provides coverage against resistant pneumococci and other common pathogens. For neonates under 1 month, the recommended empiric regimen is ampicillin plus either cefotaxime or gentamicin to cover group B streptococcus, listeria, and gram-negative organisms. A 4-year-old child has confirmed pneumococcal meningitis and is about to start antibiotic therapy. Which adjunctive therapy is recommended in this situation? A. Dexamethasone before or with the first antibiotic dose. B. Mannitol. C. Prophylactic anticonvulsants. Or D. Hypertonic saline? The correct answer is A. Dexamethasone before or with the first antibiotic dose. Dexamethasone has been shown to reduce the risk of hearing loss and neurological sequelae in Haemophilus influenza type B and pneumococcal meningitis. To be effective, it must be administered before or with the first dose of antibiotics to reduce the inflammatory response triggered by bacterial lysis. The other options are not routinely recommended, but may be used for specific complications like increased intracranial pressure or seizures. Which of the following vaccines has had the greatest impact on reducing the overall incidence of bacterial meningitis in children in the United States? A. Pneumococcal conjugate vaccine. B. Meningococcal vaccine. C. BCG vaccine. Or D. Influenza vaccine? The correct answer is A. Pneumococcal conjugate vaccine. The introduction of pneumococcal conjugate vaccines, PCV7 followed by PCV13, has dramatically reduced the incidence of pneumococcal meningitis by more than 80% in children. Before this, the Haemophilus influenza type B vaccine similarly reduced HIB meningitis by over 99%. Meningococcal vaccines are important but affect fewer total cases. BCG provides some protection against tuberculous meningitis but has minimal impact on overall bacterial meningitis rates in developed countries. A 10-year-old child is diagnosed with meningococcal meningitis. Who should receive chemoprophylaxis? A. Only siblings of the patient. B. All classmates regardless of contact level. C. Close contacts including household members. Or D. All hospital staff who treated the patient? The correct answer is C. Close contacts including household members. Chemoprophylaxis is recommended for close contacts of patients with meningococcal meningitis, defined as household members, daycare contacts, and anyone directly exposed to the patient's oral secretions. Casual contacts like classmates without close interaction do not require prophylaxis. Healthcare workers need prophylaxis only if they had direct exposure to respiratory secretions. Recommended prophylaxis includes rifampin, ceftriaxone, or ciprofloxacin, ideally administered within 24 hours of case identification. A 3-year-old with bacterial meningitis develops focal seizures and right-sided hemiparesis 48 hours after admission, despite appropriate antibiotic therapy. What is the most likely complication? A. Cerebral abscess. B. Subdural empyema. C. Cerebral infarction. Or D. Syndrome of inappropriate ADH secretion? The correct answer is C. Cerebral infarction. Arterial or venous infarction occurs in approximately 15 to 20% of bacterial meningitis cases and typically presents with new focal neurological deficits and seizures. The mechanism involves inflammatory vasculitis, cerebral vessel thrombosis, and vasospasm. MRI with diffusion-weighted imaging is the preferred diagnostic modality. Cerebral abscess and subdural empyema typically develop later and present with persistent fever despite therapy, while SIAD would not explain the focal neurological findings. What is the most common long-term sequela of bacterial meningitis in children? A. Epilepsy. B. Hearing loss. C. Hydrocephalus. Or D. Intellectual disability? The correct answer is B. Hearing loss. Sensorineural hearing loss occurs in approximately 5 to 35% of children following bacterial meningitis, making it the most common long-term sequela. The risk is highest with pneumococcal meningitis and when treatment is delayed. The mechanism involves inflammatory damage to the cochlea. All children recovering from bacterial meningitis should undergo formal hearing assessment before discharge or within 1 month. Other sequelae include epilepsy, cognitive impairment, motor problems, and hydrocephalus, occurring at lower rates. A 10-year-old child with a cochlear implant presents with fever and headache. Which pathogen requires special consideration in this patient? A. Pseudomonas aeruginosa. B. Streptococcus pneumoniae. C. Listeria monocytogenes. Or D. Cryptococcus neoformans? The correct answer is B. Streptococcus pneumoniae. Children with cochlear implants have a 30-fold increased risk of pneumococcal meningitis compared to the general population. This risk is related to potential CSF access around the implant. Other high-risk conditions include CSF leaks from trauma or congenital defects, primary immunodeficiencies, asplenia, and complement deficiencies. Patients with cochlear implants should receive pneumococcal vaccination, prompt treatment of ear infections, and education about meningitis symptoms for early recognition. Thank you for joining us for this comprehensive review of meningitis in pediatrics. Remember that early recognition, prompt diagnostic evaluation, and immediate treatment are crucial for improving outcomes. We've covered the essential aspects of clinical presentation, diagnosis, treatment, and prevention strategies. If you found this information valuable, please subscribe to Pediatric Case Review for more educational content, and feel free to leave any questions in the comments section below. Your engagement helps us create content that meets your educational needs.